Welcome friends, welcome viewers, welcome colleagues, students and residents and fellows on MuniMeterHealth, your source of learning about human cardiology and of course human heart and cardiac wellness. So this is Dr. Jaitly and welcome again on MuniMeterHealth. Remember, we are prime source for enhancing clinical outcomes based on narrowing the difference between medical education and patient education. We really want to enhance the patient health literacy. In this short video, we're going to talk to you about what are the types of heart failure. Again, it's beyond the scope of one single video, so I'm going to be talking very briefly what are the causes. What is heart failure? Of course, we like to know what is heart failure, and then the echocardiographic criteria chiefly. So, which is really the norm right now. Really wanting to distinguish one failure from the other. So, heart failure is defined where the heart is unable to meet the needs of the body's requirements. Basically, the heart function is not able to meet the needs or the requirements of the various organs in the body. So it's normally manifested by obviously fatigue. It is manifested by shortness of breath, and sometimes as paroxysmal nocturnal dyspnea, which is like waking up in the middle of the night and gasping for breath, opening up the windows, and you congest in your lungs, and then no sooner you sit up than once the sleep pattern, of course, unfortunately has been disturbed, the paroxysmal nocturnal dyspnea gets better. Sometimes with ankle edema, and very rarely into acute pulmonary edema. These are again, we'll discuss the clinical features more in details in other videos because that's beyond the scope. So let's get to the causes first. So when we look at the causes, the most important cause that you will see here is hypertension. Okay, diabetes. Now these are important ones, and then you have the dilated cardiomyopathies. Now what exactly do you mean by dilated cardiomyopathy? I'll show it to you in a second here. Now let's draw a little schematic here, if you will, to my right side of the panel. Here you have your right atrium and right ventricle. This becomes your left atrium, and this is your left ventricle right here. Okay, so having ascertained that, once we know what we are talking about, the left ventricle is the one that's in question here. And as a result of heart failure, normally what happens is, we'll use a slightly different color here, the left ventricle starts dilating gradually outwards in this fashion. And when that happens, that is the result of a systolic heart failure. That means, now remember, the ventricles are supposed to be moving inwards, correct? Because that's how you empty it out into the aorta. The left ventricle and the right ventricle will empty out obviously into the pulmonary artery. So what's happening is the left ventricle is starting to stagnate more blood, if you will, or starting to dilate because it's not meeting the functions, the normal functions of the myocardial contractility or the contraction of the muscle itself. So as a result, this starts dilating outwards. Okay, so that is called systolic heart failure. So we'll define it as systolic heart failure. And it is normally written as heart failure reduced EF, okay, because the ejection fraction normally by an echo criteria should be over 55%, as I'm writing on the left side of the panel here, which is your ejection fraction. However, the ejection fraction is less than 50. That is considered as borderline HFrEF. But if it is less than 40, you have a clinical diagnosis of HFrEF, we call it, heart failure with reduced ejection fraction. Now, so that is a systolic heart failure. What is a diastolic heart failure? So we're doing the types of heart failure before we get into the causes here. So the diastolic heart failure here, you have heart failure with a preserved EF. So HFpEF and HFrEF. HFrEF is systolic heart failure. Diastolic heart failure is HFpEF, where the systolic function is preserved, but what's happening is the heart is not able to relax too well. So here the heart will not dilate initially, and there is a diastolic dysfunction which will be seen on an echocardiographic criteria. There are different criteria. We'll have a separate video for that. But just so that you know, the ejection fraction here is preserved. Okay, so when it is more than 40, as I said, you have HFpEF, Less than 40, you have HFrEF. And in between 40 and 50, you can have a borderline. So now let's jump back to the causes. Hypertension, diabetes, and dilated cardiomyopathy. You're really covering about 85% of the entire heart failure, the causes. The next that comes in is CAD, a very important cause, coronary artery disease. Now here there are two varieties. One is post-MI, that means somebody has suffered an MI. Say the MI occurred in this area, the septal MI, or the anterior wall, or the lateral wall. As a result, these walls will not move inwards and they will actually be dyskinetic. So we can show that with a slightly different schematic. These walls will actually bulge outwards during the echocardiographic criteria when you look at. So when you see a dyskinetic movement in these septal walls, you can ascertain that this patient has had an MI, and as a result, now this patient is having heart failure as a result of coronary artery disease. So you've done two things. One, you've diagnosed heart failure, and two, you've come up to the cause, which is CAD. Very simple. So echocardiographic is a wonderful way to really know what kind of a nature of heart failure cause you're dealing with. Then there are cardiomyopathies. Well, by the way, on CAD, you should also include the ischemic cardiomyopathies here. Then you have cardiomyopathies of various nature. One is peripartum cardiomyopathy. Okay, this occurs in the third trimester, if you will, of the pregnant lady, and that may last into 6 months postpartum, and that's why it's called peripartum or postpartum, if you will, cardiomyopathies. And these patients have a 50% mortality. Remember that. These women can unfortunately die in 6 months to a year, 50, and the incidence is extremely high. So this is a very, very important entity. It should be recognized rather quickly and treated. And of course, we'll discuss the treatment of peripartum cardiomyopathy elsewhere in other videos. Amyloid, very important. Amyloid has been very prevalent, especially the diabetes or secondary amyloids or even primary amyloids. Sarcoids, which can affect the myocardium here, and as a result, patients can have restrictive cardiomyopathy or even diastolic heart failures mostly. And then you have tachycardia-induced, we call it tachy-induced cardiomyopathies, which are typical atrial fibrillation, for instance, or patients who develop a lot of VPCs over their lives, and then patients who have SVTs or PSVTs, we call them. So when they have supraventricular tachyarrhythmias, these patients can have tachycardia-induced cardiomyopathy because the heart tends to stagnate again. Because remember, the heart, if it's not allowing enough time to fill up, especially during the tachycardia period, what is happening is it is tending to stagnate and congest. As a result, you have left ventricular dilatation in these patients, the systolic function as well. And then do not forget the stress-induced. We call it stress-induced. I'm writing on top because it's commonly forgotten. A stress-induced, which is called Takotsubo, a Japanese name, a Takotsubo cardiomyopathy. And Takotsubo implies that there is it's a fishnet which sort of traps the fish, and it looks more like an hourglass left ventricle here. So here you have contractility in this fashion, whereas there's a relaxation at the base of the heart and at the apical. So in this ventricle becomes more like a hourglass in this fashion here, if you will, if I were to draw it like that. So this is where the Takotsubo comes in. Anyway, so having ascertained that, then there are different inflammations like the myocarditis. Now you may have various inflammations as a result of, say, Chagas disease. Now that could be an infection. You can have viral echoviruses, Coxsackie viruses. There's an echovirus, by the way, and there's a Coxsackie virus. So these are, we can write, and the list goes on. And even HIV has been implicated as a myocarditis and therefore leading into a heart failure. And obesity. Do not forget obesity, because that's a very, very important entity. We can include that here if you like. And then, of course, we can write atherosclerotic heart disease related to high cholesterol and vascular disease that is happening. So atherosclerotic cardiovascular disease. Thyroid disease has been implicated as well. Thyroid disease has been implicated to the heart failure. And then you have an acromegaly syndrome which can occur. And these are again various, especially for people who are interested in endocrinology, to complete the list, acromegaly. And then you have a growth hormone deficiency can occur. Growth hormone deficiency or insufficiency, GHI I call it, those patients can develop. Do not forget the toxic causes. Remember, again, we can go to the miscellaneous list as well. But toxics is very, very important. Alcohol, because it's very prevalent. I write it as ETOH. Cocaine. Now, this drug is unfortunately still prevalent, IV as well as nasal or what have you. And then you have chemotherapy agents like Cytoxan, Adria. And so these are various agents, chemotherapeutic agents, they can cause toxic. So in a nutshell, you have all these causes: hypertension, diabetes, dilated cardiomyopathies. You have coronary artery disease, cardiomyopathies related to postpartum phenomenon. The amyloid, the sarcoid, the tachycardia-induced cardiomyopathy here from various arrhythmias. Various inflammations of the myocardium called myocarditis, and these are Chagas syndrome, and then related to viral illnesses, echo, Coxsackie, and HIV. So, in a nutshell, you have all these causes, and of course the manifestations are pretty much the same in most heart failure, so you can't tell unless you have associated comorbidities which are already present, like the patient is diabetic, the patient is hypertensive, there are comorbidities. Sometimes they can exist in 2 or 3 numbers or clusters together. So the bottom line in this quick video was really to tell you, educate you about that the ejection fractions, if they're more than 40%, you have a HFpEF, heart failure. If it is less than 40%, you have a HFrEF, which is reduced EF in that setting. And anything in between 41 to 49 is considered as borderline HFrEF. Okay, reduced EF. So basically it's the left ventricle which is in question all the time, and you have to look at the wall motion abnormalities, the dimensions of the left ventricle, and the systolic dimensions as the diastolic dimensions, and then actually calculate the ejection fraction based on that, which I've discussed on other videos as well. Okay, I know it's a very extensive subject. I'm trying to give you as encapsulated information for the sake of the students and my colleagues, so this way we have a quick capsule here. Again, our goal at MuniMeterHealth is really to educate you, keep the patient education, medical education as narrow as possible so that patients are much more familiar with these terms, and we try to make it as simple as possible. Again, we are doing it for the sake of the both medical community as well as for the general community. Again, please, if you like our video, do not forget to press the like button. We appreciate that. Do ask questions, suggestions, and comments at the end of it, and we'll definitely reply to you. Make it a point to write it within 24 hours. Okay. Again, once again, Dr. Jaitly, so long, and we'll see you again on the next video.